Good afternoon, everyone, and thank you so much for joining us today, 3 days before the LPA Awareness Day. So, LPA, it's the third year that we've observed the Awareness Day as FH Europe Foundation, and 1 in 5 people globally have elevated LPA, and yet only 1% have been tested. So it's actually a very, very common independent cardiovascular risk disease. The webinar is designed to help change this. We're hoping to help, support and educate our community in their growing knowledge of LPA and, of course, elevated LPA. We have a fantastic panel of international experts who are here today to answer as many of your questions as possible. We've had such so many questions have been sent to us, and we're going to do our best to answer them all this evening. We've had over 130 people register this webinar. It is being recorded as well, and so if you aren't available to watch now, you will of course be able to pick this up on our YouTube channel at a later date. So before I introduce the panel, I would like to do a little bit of housekeeping. This is being recorded. As I've already mentioned, it will be available to watch on YouTube. And feel free to ask questions as well. We've got the chat box. The chat box is available to say hi and where you're from, because we'd love to know a little bit more about you. And then the Q&A box is designed for our panelists to see, so they can answer any questions that you may have. And I'll do my best as moderator to incorporate them into the conversation as we go along. Okay, so without further ado, I'm going to introduce our amazing panel. I'll start with Professor Pia Kamstrup, and I have to say congratulations, because she has just received her professorship, or was just about to. So Pia is the Chief Physician and Head of Department of Clinical Biology in Denmark. She has contributed to the International Research Collaboration's consensus paper on LPA lowering, and she's a member of our LPA Taskforce. We have Professor Florian Kronenberg, who is the head of the Institute of Genetic Epidemiology in Innsbruck at the university, and he's also chair of our international task force. We have Dr. Jay Segler, who is a consultant in metabolic medicine at Imperial College of Health in London, and she liaises and works with patients on a day-to-day basis. And we also have our youngest member, a patient living with elevated LPA, and this is Aidan Carl, who is 18, studying medicine at the University Medical Center of Amsterdam, and he's also on the youth panel as well for the European Patients Forum. So thank you all, and thank you for joining us. This is a new format we are trying. So with Ask Me Anything, we've adapted the format a little bit from our American colleagues at the American Family Heart Foundation, and we're taking it up another level. So instead of having one expert answering all the questions, we've come together as a panel today, a panel of experts to answer your questions, which you've kindly directed to one of us in turn. And we will also open it up so that it becomes more of an informal chat, which I hope you'll enjoy and you'll find informative. Before we go on to the questions, we have a very quick poll, if we can bring it up on the screen, please, which we'd like our audience to answer, very simple. It will take you a matter of moments. And if someone can share the votes when we have them through. Okay. I'm not 100% sure that the still voting. I'm being too quick. I do apologise. Bear with me. It's great to see so many of you are voting. That's the key thing. And then it's really helpful because then we can see who knows what and how it will work. Well, fabulous. So I'm very pleased to see that 86% of you know something. So we're talking to a reasonably well-informed audience already. So that's wonderful. And have you ever had your LPA levels measured? 66% of you have. So that's really great to hear. And again, it will help with the way we formulate and answer your questions. So thank you for that. And without further ado, we'll go on to the questions that we've received. Brilliant. So because we had so many questions, we've actually sort of clumped them together just to allow for time. So we've got a section on high LP(a) and treatment. So a lot of the questions were around, as you can see, if really key and really important questions. Is it curable? What is the best treatment? Can levels be controlled with aspirin? If LDL-C is kept quite low, is LPA really significant? And what about niacin? And will we have any effective and affordable treatments in the future? So, Florian, if I can direct the question to you, is it curable, or is there any chance of healing at all?
Yeah, I would like to start first with a statement I usually make. I consider LPA as a freak of nature. That means this is something which you inherit, yeah, and you get it from your parents, whether you have genetic variants which are going hand in hand with high LPA concentrations. And there's always the question coming up, what is a high LPA concentration? And we know that the higher the concentration is, the higher is the risk. And we usually say that people who have LPA concentration, let's say about 50 milligram per deciliter, or if you use the other unit like 100 to 125 nanomoles per liter, then it's going hand in hand with an increased risk. But there's, of course, we know very well that the higher the concentrations are, the higher is the risk. Yeah. And I would not really call it the value of LPA, the concentration of LPA, I wouldn't call it a disease. Yeah, it's a condition. Mm-hmm. This can result then finally sometimes in a disease that someone gets a heart attack, and not everybody who has a very high LPA concentration will get sometimes a heart attack. This is also a very important question. Otherwise, people start to panic, and there's no real reason to panic about this, because we can do already now something. That is my first statement I would like to make. Maybe other ones would add to that.
Thank you, Florian. And I absolutely agree with you. And on this point of panicking, can I just bring in Jay for a second? Because Jay, you're in the clinic, you see patients day in and day out, and it must be essential to reassure them that particularly when they first get diagnosed, that it doesn't necessarily, that it is a risk factor, an independent risk factor of cardiovascular disease. It doesn't mean to say that it will become cardiovascular disease. Would you be able to jump in?
Absolutely. Emma, I think you hit the nail on the head with that. So we think of it, you know, it is a risk biomarker. So it's a biomarker, it's something we measure, and it tells us something about global risk for someone. And that's based on studies, so epidemiological studies, you know, where lots of people come in together and we look at the risk and how that increases with Lp(a). I think sometimes there's a bit of a concern when we call something a disease or not a disease, and we make it binary, that people fall into two camps. And actually, as Florian said, that risk is a continuous, so it's a continuum. And, you know, we know that at those very high levels, that risk is much higher, but in the majority of people have quite low levels of Lp(a). And whether it's curable is a really interesting question. I think you know, at the moment, we don't have very sort of great ways of potently lowering Lp(a) other than things like apheresis, which is obviously sort of quite a radical way of treating Lp(a). But we can do a lot in treating risk in general. And I think that's the way we really need to be approaching it. I don't know if, Pia, do you have anything to add to that, the way you think of Lp(a)?
Well, please just allow me, well, thank you for the kind introduction, Emma, and just allow me one small correction. I did not contribute to the European consensus statement. I was on the American Heart Association scientific statement on Lp(a). So let me just say that I completely agree with Florian and Jay, and I've had the privilege of working scientifically with Lp(a) for many years, and have access to some very large general population studies, and it's completely correct that what we look at is relative risk. So you may have a 2 to 3-fold increase in relative risk when you have high Lp(a) versus when you have low Lp(a). But that does not necessarily tell you anything about your absolute risk of actually getting cardiovascular disease, because that's the sum of all your risk factors. And we can see in our data, based on more than 100,000 individuals, that if you succeed in keeping all of your other modifiable risk factors low, like LDL cholesterol, your blood pressure, you have reasonably BMI, you are physically active, your absolute risk of actually getting cardiovascular disease will remain low, even if you do have high Lp(a). And I think that's a very important point to make.
Thank you, Pia. And actually, we have some additional questions further on that look with some case studies, actually, with people who have a calcium score of 0, and what can be done, and also talking about health and diet and any other global risk factors, as we mentioned. So we will touch on those. Just before we get there, I would like to, yes, we've got this brilliant example up here now. Reading through this as a panel, this question was originally directed to Florian. Is this level, this gentleman who is 60 and has the levels latest measured of 133 nanomoles per litre, and his LDL oscillates between 1 and 1.5 nanomoles per litre. Is this sufficiently low?
Yeah, here we have a gentleman who has already cardiovascular disease. We call this secondary prevention, and finally, and there the targets for LDL are quite low, and with 1 to 1.5, he's in a good situation, we can say. So he did already everything when it comes to lipids. He did already everything what can be done. But we do not know at this moment whether there are other risk factors in that person, whether the person is smoking, whether there's an hypertension there, whether he's overweight, or whatever risk factors we have in our mind. So the very clear message is whatever risk factors are available should be treated. And here we have an LDL of 1 or 1.5. I think we are already in a relatively good situation. And he gets everything for lipid lowering, what we have as tools available. And this is really great that we have those tools. Yeah.
Yes. Thank you. And yeah, it's so important that we have the tools, but as you said, without the additional information, the other global risk factors, that is also important. I'm just looking at the units here, Florian, as well. We can see that it's in nanomoles per litre, but my understanding is, of course, that we have milligrams per deciliter. And in the UK, we also have milligrams per litre as well. So I'm just wondering if Florian or Pia or Jay would be able to comment on the importance of the units and the importance and significance of knowing which unit you're being measured in, because with 3 different types of unit, it can be quite confusing, I think, from the patient perspective, as to whether it's high or not high or low, for example. Pia, would you like to comment?
Sure. First of all, it's hard not to agree that the current situation is not ideal. I would like to make the point that while we await international standardization of assays, and we have, as a scientific community, agreed to progress towards giving out answers only nanomoles per liter, those assays that are out there that give you your test results in milligrams per deciliter are also perfectly capable of identifying if you are at increased risk due to Lp(a). So when you talk about Lp(a), it's very important that you not just give a number, but you remember the unit. Because as a rule of thumb, if you wish to convert from nanomoles per liter to milligrams per deciliter, you divide by 2. And then, of course, if you wish to go between deciliter and liter, you have to remember the factor of 10. So we are working towards, as a scientific community, the international standardization of levels, which will hopefully result in the use of the nanomoles per liter unit everywhere in years to come, and also that assays are directly comparable, so that if you have your Lp(a) measured at one healthcare institution or a lab, it's comparable to a result you would get from another, from say your general practitioner. So it's important when we talk about Lp(a) that we remember the units. Otherwise, we confuse each other.
Great, thank you, Pia. That's really helpful, and a great overview of the importance of knowing your units, but also that it doesn't matter which unit it's measured in. The calculations can be done to change it. So whether you're measured in one lab in one unit and another lab in another unit, which I personally have experienced, it's absolutely fine, and you don't really have anything to worry about there. And at some stage, hopefully, we'll have a universal measurement, but I think that's probably a way off in the future at the moment. Yep. Okay, and if we could just go back one slide, please. Thank you. I just wanted to ask, on a regular basis, when we're having webinars about Lp(a), we often have a question about niacin. And so I'd just like to ask the panel, I'll start with Florian first, if I may, as the question was originally directed to him. Does the panel honestly believe that niacin should not be used?
This is an interesting question. We do not really have a study which looked, a big study which looked at patients who have high Lp(a) concentrations, and they were introduced in that study and were then treated with niacin. So we do not really know what would happen if we would have really a typical study where we include those people who have the very high LPa concentration, whereas niacin would doing something good. But I think we can discuss about this a long time. We have to face the situation in most countries in Europe. Niacin is no longer available, yeah, and so therefore we cannot really use it. So in some countries it's there, and some people are using it still, but we do not have really solid data which show that the lowering of LPa by niacin, which is I think in the amount of 30%, whether this would do something good. We simply do not have the data.
Okay. Thank you, Florian. As you said, I appreciate it is available in some other countries.
Emma, if you don't mind, could I just add to that
Absolutely,
about niacin? I mean, there is a reason that the EMA and in our country, the MHRA withdrew niacin, and that was based on a large trial that didn't show cardiovascular benefit. And the reason we care about LPa is because of the cardiovascular risk. And okay, this didn't study a specific population with a high LPa, but in a more general population, the side effects were deemed severe enough compared to the benefit, and that was the reason that the EMA withdrew it. So there is a reason why it's been withdrawn from the market.
Okay, and patient safety at the end of the day,
absolutely,
is most important. And Pia, do you have anything to add on to that as well?
I completely agree. I think that topic has been beautifully covered.
Brilliant. Thank you, everyone. Much appreciated. We'll go on to icosapent later, as we do actually have a question later on about aspirin, so we can combine that then, if everyone is okay about that. So a final question in this section is, will we have effective and affordable therapies to manage elevated LPa going forward in the future? As I'm sure a lot of our viewers are keen to know this, especially those living with elevated LPa. And that was open to everyone. So Jay, would you like to go first?
Yeah, I hope so. But I guess we're waiting for the science to tell us. And first we need to know about the efficacious of there's several trials going ahead at the moment of various agents. They're big trials, and they're really asking the question: if we potently lower LPa, can we reduce the risk of heart attack and stroke? And yeah, we need to wait for the answer. These trials take reasonably long, so 3 to 5 years to see a difference between a placebo group and the active arm, and we should have that answer hopefully in the next couple of years. Of course, these are only being done at the moment in predominantly in secondary prevention. So primary prevention, we will have to wait longer. The affordability, I don't know. I think we'll have to see about that, and it'll depend on individual nations and cost effectiveness, etc., to make decisions upon that.
Thank you, Jay. At this stage, as we've just spoken to Jay, who is a clinician, I'd just like to bring in Aidan as well to get the patient's perspective. Actually, Aidan, what are your thoughts? I'm assuming you're hoping in the future that there will be more effective therapies available to you. Yeah,
absolutely, yeah. As a patient and as knowing a couple of other patients with elevated LPa, everyone's thrilling for like the perfect therapy to reduce everything. So we all understand that it will take quite a while for it to achieve and for it to be properly there. Most of the treatments that I'm aware of, it tends to be focusing around risk factors, lowering those to the maximum amount, and then treating it like that. And that is it works, but it is very time consuming, and it is rather, and for one person, it's easier than for the next, especially depending on age. If you have to sport a lot and you're 60, that's more difficult than if you're 20, for example. So everyone would love to have an affordable and effective therapy, but for a medicine that you could take once and then boom, it's done. but unfortunately, that's a dream that we have to keep on dreaming for now.
Yeah.
But yeah.
That's great. It's good. Did you want to add, Aidan?
Hmm?
No? Okay. Thank you for sharing your patient perspective. I am aware on time, and I think it would be advisable if we moved on to some of the other questions. We've got wonderful questions. I mean, this right here is a fabulous question because it's multifaceted, and it just gives a beautiful example of how many different things there are going on with elevated LP(a). So again, it is mainly based on treatment and the medicines, but as Florian had mentioned earlier, and Jay and Pia, does diet have an influence? It's the global risk factors. It's whether people smoke or drink or exercise, and taking into account PCSK9 inhibitors and apheresis, and it is multifaceted. Would anyone like to jump straight into this? Again, I think this one is directed at, yes, it was directed initially at Pia. If you'd like to pick an element out of it, Pia, I think that's probably the best way of approaching it.
What a beautiful bouquet of questions.
And that's a wonderful way of putting it as well.
Okay, well, just looking at the word diet, of course, eating a heart-healthy diet is part of any multifaceted approach of being at risk for cardiovascular disease, including high LP(a). So a Mediterranean diet would be preferable to a diet rich in saturated fats, for instance. So a heart-healthy diet is always important, and is particularly important when you have high LP(a). I'm not saying it will alter your LP(a) levels, but it will work towards reducing your overall global absolute risk of getting cardiovascular disease. So if I should pick one other thing, there's something about is genetic testing needed. And now we're all talking under this beautiful logo of FH Europe Foundation. And for FH, of course, genetic testing is indicated. That's not the case for a high LP(a), because genetic testing in LP(a) is a wonderful research tool, and a tool that has been used over the years to provide very strong genetic evidence of causality between high LP(a) and risk of cardiovascular disease. And it's my firm belief that that is what has also driven the field towards where we are now eagerly awaiting cardiovascular outcome trials results. Without the genetic evidence, I don't think we would have gotten there. But whether it's needed for individual patients, no, it's a research tool. A plasma, just a simple blood sample and a measurement of your LP(a) levels in blood will suffice in risk prediction. So I think I'll hand over to the rest of the panel to pick a favorite question from this yeah, very nice selection of questions.
Florian, would you like to jump in?
Yeah, I can take the question about children with elevated LPa. I think one of the most important things is when you have children with elevated LPa concentrations that you really convince them that they should not start bad behavior in the sense of bad diet, no sports, and all this stuff, smoking. Because if you keep away from those things, then you have already a good starting point to avoid accumulating changes in your blood vessels, which will result then finally in cardiovascular disease. So I think that's a very important point, and sometimes it has to come not from the parents, this advice, because then it's often not followed. So the medical doctor, those who are really counseling a family, should tell them. Hopefully, then they follow it, and not the parents. And I think there's no need to start already medicine, let's say, when children is 8 years old, except there is a familial hypercholesterolemia there, then we start very early. But for LPA, we do not have any possibilities here. Yeah, I think that's all what I want to say about LPA. Maybe the question which is often coming up, when should we start to test for LPA concentrations? In the consensus paper, we say LPA should be tested in all adults, but we can already measure it much earlier. So usually LPA starts when at birth LPA concentrations are quite low, then they increase till the age of 5, and then they still slightly increasing up to the adulthood, up to the age of 15, 18. But I think especially Pia, you might have already data that you can already measure LPA at the very earliest ages, and then you can get an idea whether someone will have later much higher LPA concentrations. I don't know whether you would like to add something on that.
Sure. I agree with everything you said, but it's true that levels are very low at birth. We've looked into a sub-study of the Copenhagen baby heart study where we have LPA levels on trios, mother, fathers, and newborn babies, and also actually cord blood. And what we can see is that levels are indeed very low in cord blood and in venous blood samples taken just after birth. But what's striking is that even though levels are low, they still have this very skewed distribution where some of the newborns have relatively high levels compared to the majority of the newborns. And those are actually the children who go on to have the highest levels. So actually when the children reach about 15, 18 months of age, they've almost reached the levels of the parental levels. So it does, I mean, it's interesting to know these data and know more about the biology of LPa, but it's in a very futuristic perspective. It does open the possibility that this is something that could be screened for at birth. Not at all something we should be doing now. I completely agree with the consensus statement that ideally you should have your LPa measured at your first lipid level measurement as an adult. And I do know that we have a challenge also for just measuring LDL cholesterol and all. And this is just one more reason why it's important to know your lipid levels, because you can live, have a healthy lifestyle and be surprised that you are still genetically predisposed to high LDL cholesterol and or high LPa.
Brilliant. If I may jump in here as well, thank you, Pia, for your answer there about testing young and all the way up to the sort of the youth age, which is where I would like to bring Aidan in now. And we're just bringing in a question specifically that we received from Aidan. So as a young patient representative, Aidan, how have you been able to manage your elevated LPa? Many of the viewers out there will have small children and they are worried about getting them tested. And then once they've been tested and they've been diagnosed, they have no ideas about what to do. So how did your parents support you?
Well, I would like to start by saying that they should not worry about testing them and that they should definitely get them tested as soon as possible. That's the first thing. Secondly, in my case, I was tested when I was 6 years old, so I was quite young. And what happened is in that period of time, my parents were already trying to teach me the ways of having a healthy heart diet, for example, but also the importance of sporting regularly. And the younger you are, the more value you take into that incorporation. And then having a doctor that explains to you additionally, if it's a child, very simple steps, but if it's a teenager or almost an 18-year-old, then just realistically, it could help a lot. Say you are a small child of 6 and you're told you shouldn't smoke, then as funny as it might come over, they will not forget it. and especially if the doctor tells it to them and the parents tells it to them as well, because as Florian has mentioned before, if your parents tell you something as a child, you tend not to follow it. But that is one of the most important things. And then just focusing on your healthy hard diet, focusing on your sporting, taking your medicine if applicable. It depends. And the most important one of all, watch out when you're crossing the road. But there are many factors that you need to take into account, though most of them are just lifestyle based. So if you tell the child, hey, you need to manage your lifestyle in this way, and we're willing to help you out in figuring out how you should do so, then the child should have no trouble at all.
And especially when we consider now, we are here, let's say we have a person who is 6 years old, and then we are going in the future, in 10, 15 years, we might have all these studies which show us that LPa lowering is also maybe lowering cardiovascular events. Then we might be in a good situation, and because then we have medications available, even in the primary prevention setting when all these studies are done. So this is a good situation. And if someone would have told me, let's say 20 years ago, that sometimes we might be able to lower LPa concentration by 80–90%, I wouldn't have believed that. So this is really exciting times now, but we have finally to wait for the results of the trials to see whether it's also lowering not only LPa concentration but also cardiovascular disease. So hopefully in 2 years we know it.
Yeah, and to add to that, the younger the child tends to be, the easier it is for them to manage this lifestyle because they're still learning it. If the child is, for example, say we were speaking of someone of 6 to 8 years old, then and their parents would tell them, hey, here you need to focus on your diet, you need to focus on your sporting, you need to do this and this and this, so reduce your risk factors overall. Then it's very easy for them to learn this because they don't know any different. But say your child is already entering teenage, already entering the rebellious state in which they don't want to listen to their parents or for whatever teenage reason there is, then having a doctor level with them and talk to them, hey, if you do this, this, and this, you reduce the risk factors of this, this, and this, that helps a lot. So for every age, there is a possibility of just being able to live with this perfectly fine.
So it's teamwork between
yes, it is
patients,
definitely
parents,
teamwork.
doctor, and so on.
If in the most ideal situation, you have the parents with the child and the doctor all together being informed. That's the ideal situation. Emma, I believe if you're talking, you're muted.
Thank you. Gosh, I've not made that mistake for a while. Thank you, Aidan. I was just going to say that, yes, a collaborative approach between the parent, the child, and the healthcare professional is definitely the way forward. I'm on the same subject as children. I'm just going to move us on because we've had a couple of questions here. So again, this gentleman is concerned about his daughter, who is 4. And he had a heart attack at the age of 28, is on medication. And he is wondering if she is too young to start taking medication, and how old you would actually start medication. Aidan, were you actually 6 when you started, or did you start taking medication a little bit older?
The first advice that I got when I was little was health style. So it was just lifestyle based. And being a child, being told, like, the first thing my doctor did was look me in the eyes when I was 6 years old and asked, do you smoke? And though that was quite funny, I'll never forget the fact that you shouldn't smoke in this situation. So bringing it in a light way always helps. Great.
And but this question is initially directed at any of the panel. So if I can bring in Jay and Pia and Florian, and Jay, I imagine as a clinician you do see parents with their children asking exactly this same question.
Yeah, I have several patients in this exact scenario, and they worry about their children, understandably. And The thing is, there's no one size fits all, and you have to take in the individual circumstances of each family, you know, the levels, the history, the other risk factors, and also different people's perception of risk and how they want to deal with that. Some people want to, you know, wait a little bit, manage with lifestyle. Some people are very keen on starting medicine early. And, you know, I think we take all of this into account and make sort of a shared decision. And that's really how I approach it. But yeah, this is not an uncommon situation. I think we're going to be seeing this more and more as testing becomes more widely available.
Thank you, Jay. And we've had a couple of questions come into our chat box as well. One is, what are the recommendations for testing the pediatric population? And a similar question is, what age group, is there a specific range for testing people for elevated LP(a)? Is it best to test as young as possible, as Pia was mentioning earlier, or is it best to wait a little bit longer? Both questions from our viewers at the moment online.
I think, I mean, the evidence in children is much less than the evidence in adults, you know, the epidemiology, etc. And certainly sort of in the UK, our guidelines are very much sort of geared towards adults and waiting to test till the age of 18, unless there's a specific situation, sort of, you know, premature stroke or something else that's going on in the family or the child themselves. So we tend to generally wait till adults, and I think that's also what the European guidelines suggest.
May I jump in here? I think we have to distinguish what we are testing, and I would never recommend to test LPa alone. I would like to see always the global picture, and to the global picture also the LDL cholesterol fits. And we can of course discuss when should we test for LDL, if we have to keep in mind that we might detect a person who has familial hypercholesterolemia. Then we would like to detect this quite early. So because we have treatments available 10 years of age that we can really treat them with LDL lowering drugs. And I think this is a discussion going on in different countries now. And I think it depends also in which country you are living, whether you are in a country where they would like to test this quite early to identify those who have familial hypercholesterolemia. And I think this is a discussion which is going on at the moment. And to detect those with familial hypercholesterolemia is very important. And there you should not make your first lipid panel at the age of 40, because then you have already lost many years where you could have treated the people quite well.
Thank you, Florian. And well, we'll just answer this one more question regarding children, and then we'll move on to the topics about CVD and women, two separate topics, because I'm very aware we're quite tight for time now, but there's just so much incredible information that people are asking, and the questions our expert panel are giving, but I will swiftly move on. Very quick question about aspirin and aspirin as a medication for lowering or reducing the cardiovascular risk with high LP(a) in children and in adults, and panel as a whole. I'd like to hear your thoughts on this. Pia, would you like to go first?
Well, with the slight disclaimer that I don't see patients, I'm not a practicing clinician, so I'm very much looking forward to Jay's answer. I think you should go by the guidelines. You should use the medicine for which there are approved indications, and I will concur that the epidemiologic evidence for LP(a) in children is weak. There are casuistic descriptions of children and those rare events of stroke and high LP(a). And in that case, I would leave it entirely up to the discretion of the doctors and specialists treating that particular family. And of course, doctors are allowed to make specific decisions and perhaps go off label even in special situations. But I would in no way recommend screening children widely for high LPA and widely giving aspirin on this indication. There's no data supporting that approach, none.
Emma, can I jump in as well?
Please do, absolutely.
Agree with Pia, and aspirin we are using very much on a case-by-case basis in primary prevention. So in terms of the evidence for it, there are unfortunately no randomized clinical trials specifically asking, if you have high LPA and we give aspirin, can we reduce the risk? There's observational data that looks at this, and that is suggestive that actually aspirin may be beneficial, but it's not really sort of didactic, clear evidence of this. So we're really thinking case-by-case basis and having that discussion with our patients about the lack of evidence here. It is really something that we need to do a proper clinical trial on to really answer the question properly.
That was also the reason why we stayed away from that in the consensus paper, that we say that we have in primary prevention, we have no data on that. So a clear trial on that. And when we do such recommendations, we have to have always trial evidence. Otherwise, you might run the wrong direction.
Yeah. Thank you, everyone. If it's okay, due to time, I will move on to our next set of questions, which is about LPA and women. So the first question, which I will put out to, both questions are directed to Pia, actually. Can I use estrogen gel for menopause symptoms? And then we have the more detailed question related to current research around HRT and how this may influence LPA levels in postmenopausal women. And as a person has specified, the interest is strictly in the potential effects of HRT on LPA levels, rather than as a debate on HRT itself. It's good to have that in there as a caveat. So Pia and Jay, I'm going to hand this over both to you, one as a researcher and one as a clinician.
As a researcher, I can say that we do have data from our large population studies showing that although LPA levels are primarily genetically determined and thus relatively stable within the individual, we do see, when we look in a large number of individuals and a large number of women, that there is some increase in levels around the time of menopause. And so that high LPA levels may be somewhat more common in women than in men after the age of 50. But that's, epidemiologic data. I think I'll hand it over to Jay from here.
So no, I agree. I mean, we know that LPA goes up, with menopause from the studies that Pia and colleagues are doing. And the question about HRT and reducing LPA is a different one. So also with menopause, we see an increase in LDL. This is something else that is probably underappreciated. And we know that HRT can reduce the levels very modestly of LDL cholesterol as well as LPA. Again, no sort of trials looking specifically at this. This is observational, but we would never at the moment in clinic use HRT specifically to lower LPA as such. Generally, we're really using HRT in people who, for very specific reasons, they're symptomatic or premature menopause, etc. But there's no evidence that we can reduce cardiovascular risk in these patients with HRT. So we really stay away from HRT for specific cardiovascular benefit. It's really about symptoms, and that's why we're using it.
And may I add here something? I think that's a good advice when a woman is coming into menopause, then to look at the lipids once again. because I know so many who had wonderful LDL levels of 100 milligram per deciliter when they were young, and then they were surprised when they measured their LDL concentration with the age of 55 or so, and it went up to 170, where we would clearly give advice to treat that. Yeah, and I think that should be really carefully looked at when they are coming to the menopause. Check once again the lipids. There was also discussion whether LPa is going up then like a rocket. This is not the case. Usually it's going up slightly, maybe 15 or 20%. If someone has the time before LPa concentration of 10 milligram per deciliter, it's not going up to 60 milligram per deciliter. And those who have maybe between 30 and 50 milligram per deciliter, maybe it's going up then to 60 or so, yeah? But it's not changing the risk category dramatically in most of the people.
Thank you, Florian, and thank you, Pia, and thank you, Jay. I'm hoping that's answered the questions that we received on LPa and women, and help people, reassured people that the higher levels aren't anything to worry about too much. Moving swiftly on, because we have 9 minutes left until the end. We have a section on LPa and CVD. If we could just switch over to those slides, please, that would be helpful. Won't be a moment. Here we go. Higher LPa and no CVD. And we've also had a few questions in the Q&A box as well from our audience. So I'll do my best to link those in as well. So are there any cases with elevated LPa and no demonstration of cardiovascular disease? We touched on this one earlier, I believe. And another question is, what is the mechanism by which statins raise elevated LPa levels? To what extent are the LPa levels raised during an acute inflammatory process? And how long will this elevation persist? How do you explain that certain people live with extremely high LPa levels and without any sign of atherosclerosis? I really need to learn how to pronounce that properly. Panel, please, if one of you could jump in if you're particularly keen on answering this question, by all means, go ahead. So,
Jay, would you like to answer maybe the question about the statins, because you are facing this problem maybe on a daily basis?
Yeah, so this is something that is has been seen in a few studies, that with statins, you get a very modest increase in LPa, something like 10% or so. I mean, these are not huge studies, and this is, there's, I think, 1 or 2 meta-analyses that have been published on this. So I think the jury's a little bit still out on this. What's really important to remember is that the statins potently reduce LDL cholesterol, and that is the main driver of atherosclerosis and heart disease. And so the benefit of the statin far outweighs any modest or minor effect that it may or may not have on LPa levels. And so I think it's really important to put this into perspective. Don't focus too much on the number of LPa. There is a little bit of biological variability. There is some analytical variability as well. Rather think about, that overall global cardiovascular risk. And we know from many, many trials that statins will reduce that best through, through the LDL lowering. Florian, anything else to add to that?
You answered that question wonderfully. Yeah. And I would like to pick up the one issue again about the high LPa concentration, whether everybody gets cardiovascular disease, because this is so important to mention that there is no guarantee if you have an high LPa concentration that you will get a heart attack. So because it depends always at the potpourri of risk factors you have. If you have a lot of risk factors and you have a high LPa concentration, that risk is increasing. Yeah? But if you have no other risk factors and then have an LPA concentration, the risk might be quite low. And we have to keep in mind that roughly a third of the population is dying from cardiovascular disease. And there are this group of people who have the very low number of risk factors or no risk factors and have high LPA concentration, then they have even a lower global absolute risk than the other ones who have the many risk factors and high LPA concentration. So please always keep that in mind. Never focus on a risk factor, on one risk factor alone. Look always at the potpourri of risk factors, and that makes the picture. And that gives you also an advice what we can do then finally about it.
Excellent. Thank you, Florian. And with only 5 minutes to go, I am actually going to have to start wrapping everything up, as we've got a survey to send out. We've got the poll to do in a moment, and I appreciate very much all of the questions that we received online in advance, all of the questions that we're receiving in the Q&A, and I recognise that we've not been able to answer all of them because the questions were just so fantastic and the answers from our amazing panel have been so detailed, and which has been incredibly important. So what we will do over the next couple of weeks or so, a bit longer because of Easter holidays and things, is we will collate the information and we'll put them together in a PDF and send them out to the community so that people have detailed information, particularly about the questions that we haven't had time to answer. This was almost an experimental method of presenting a webinar, just to do a different format, to inform and educate. And the response we got was fantastic. So I really appreciate that. Before I say a final thank you to everyone and wrap up, maybe bring the poll up again just to see if the webinar this evening has, I'm hoping, enhanced everyone's learning, and you've now gone from 86% of people having a reasonable amount of information to going, yes, we're all experts in LPa now. And any of those of you, the 66% who have already been measured, maybe some more of you are interested in having your levels measured. I'll give you a few moments, and while that's while the poll is going ahead, I would just like to say, obviously it's LPa Awareness Day on Sunday, so please join our campaign on social media, either by reposting our posts, liking, sharing, whatever you can to help get that message out there, and we will continue to share and talk about LPa. Coming forward into May, we have our first HOFH Awareness Day as well. So there'll be more information coming out about that in the near future. As I've previously said, the webinar will be is recorded. It will go on our YouTube channel. There should have been links going in the chat box about where you can find different videos and previous webinars about LPa, the consensus paper, and the LPa brochure that FH Foundation produced as well in conjunction with our patient ambassadors. And yeah, I'll just see if we've got any results from the polls in yet. Yes, so I'm pleased to see you do feel that you know more about LPa now. I'm glad about that. And 38% of you have said that you will go ahead potentially and have your levels of LPa measured. So thank you for completing that. And one final thank you to our amazing panel of experts. Professor Kamstrup, Professor Cronenberg, Dr. Segler, and also our amazing patient ambassador, Aidan, living with LPa. Thank you all for your time, and we look forward to seeing everyone at a webinar in the future. Thank you. Have a good evening.